my task is to deal with the concept of cardiovascular disease risk in patients on ADT. And by the way, I'm going to talk on Wednesday morning, I think, on the metabolic aspects of ADT and advanced prostate cancer. But we could combine those two talks, but we have 15 minutes for this one and 10 for the next one. Here are my consultant advisory board activities. All right, so the most common non-prostate cancer cause of death in men with metastatic disease is cardiovascular disease. And ultimately that form of cardiovascular disease can occur in valvular heart disease, it could be heart failure, it can be cardiomyopathy, it could be cardiac rhythm disturbances, and also it can be coronary heart disease. So it can take a wide variety of flavors. Valvular heart disease is a little bit unusual in this group of people, but the other types of heart disease are all present in people with this. So what I'm going to do here is review with you a study that ultimately looked at a cohort that analyzed a sample of 26,000 U.S. men who received a diagnosis of metastatic prostate cancer from the interval of January 1st, 2000 to December 31st, 2016, and the data were analyzed up until July of 2020. So what we see here are the causes of death. Now, advanced prostate cancer is by far the most common. But if you look at other causes, if you look at the combination of stroke and coronary heart disease or cardiovascular disease, it's 10 to 15% of deaths are due to that. And other things here, respiratory disorders and other disorders, other cancers, et cetera. But anyway, this is an area that you guys and gals need to be concerned with if you're taking care of people who have advanced prostate cancer. Now, if you look at the gene expression of genes that are expressed in these kinds of patients, it's interesting to look at the overlap. So on the right are the genes that are shown to be increased that relate to the risk of developing prostate cancer, but then from right to left are those genes that predict adverse effects, particularly in cardiovascular disease. So it's kind of interesting to see there's a certain number of signatures that might be able to predict who's at risk not only for prostate cancer, but also who's at risk for cardiovascular disease. Now, here's a list that I'm not going to go down this systematically, but if we're looking at ADT and the various agents that are utilized there, we see all kinds of heart disease. But I think the theme that you're going to see from ADT to second generation androgen receptor blockers, androgen metabolism inhibitors is a prolonged QT interval. And I'm going to show you a slide in a second that shows cardiac arrhythmias is one of the most common forms of heart disease death in people with existing extensive metastatic prostate cancer. Now, but is there a standardized approach? I mean, these are all kinds of NIH grants that are undergoing clinical trials to look at how you all assess people with advanced prostate cancer and their risk for cardiovascular disease. I'm not going to go down this list. I'm just showing you there's a lot going on here. But yet, unfortunately, there's not been a consolidated approach. Now, if we look at the various agents, and GnRH antagonists are in red, GnRH antagonists are in dark blue or purple. Blue is bilateral orchiectomy, and green is androgen synthesis inhibitors, and finally androgen receptor inhibitors. You can look up and down this slide in terms of all forms of heart disease, including cardiac arrhythmias, heart failure, hypertension, coronary heart disease, and down here, diseases of the vasculature. And you can see all of these drugs, some of them play a role in many of these outcomes, and some play less of a role in others, and some no role in others. So I think this is a list you don't have to know so much about, but I'm going to end this talk with an idea how we might better approach this. So one of the questions that comes up is how important is pre-existing cardiovascular disease in patients who have metastatic prostate cancer and ADT on cardiovascular disease outcomes. So this slide just shows you a variety of manifestations of people with cardiovascular disease, and I'll not go into detail about that. But here we're looking at adjusted hazard ratios of CVD events with or without ADT exposure, and in the red are people who, in fact, on the far right of each of these bar graphs are the people that have pre-existing cardiac disease. And if you look here, consumption defects or cardiac arrhythmias, and finally stroke seem to be much more common in people with pre-existing cardiovascular disease. But importantly, and kind of interesting, is that ADT was associated with an increased risk of heart failure adjusted for multiple variables in men without pre-existing cardiovascular disease. So again, a large survey of nearly 8,000 people with prostate cancer who were nearly 30% of them were exposed to ADT during their treatment paradigm. So this is some important information. Cardiac arrhythmias and stroke are assumed to be more common in people with pre-existing disease and those without, from this particular survey, heart failure. And now if we look at agents used to treat people with advanced prostate cancer, including abiraterone and also enzalutamide, we see having numbers of risk factors, particularly for abiraterone, here showing 3 risk factors versus less than 3, modifies survival in patients with advanced prostate cancer. And here with enzalutamide, we see 3 risk factors particularly more harmful than just having 1 or 2. So again, the concept having pre-existing disease is relevant in your patients, but how much time do you as urologists have to assess this kind of paradigm? And I'm going to say not very much. But the other aspect of advanced prostate cancer, which you know a lot more about than I do, is the use of chemotherapeutic agents and immunotherapy. And ultimately, we know that Taxol derivatives modify microtubular function, and look at all the types of heart disease that relate to Taxols. And that's particularly important in other forms of cancer other than prostate in terms of some of the cardiovascular disease complications. And then the PD-1 inhibitor, pembrolizumab, ultimately causes a lot of problems too, including myocarditis. And then we'll cover these in a little bit more detail in a second. But sepofarsen also targets PSA, but also is associated with an increased risk of cerebrovascular events. Now, in 2010, I was part of a group with the American Heart Association that casted this recommendation of androgen deprivation therapy in patients with prostate cancer and how to assess cardiovascular disease risk. And here's a list of things that we thought should be measured, some observations about how advanced therapy, by the way, multiple societies here, including your own, increased fat mass, ultimately increased LDL, cholesterol, and triglycerides. By the way, HDL also goes up, and that's kind of problematic. We might come back to that in a moment. Increases in systolic blood pressure, and decreases in insulin sensitivity, increases in fasting glucose, et cetera. So we got a wide variety of things that are modified adversely in patients with advanced disease who are treated with ADT or other therapeutic interventions. Now, while there exist guidelines and risk calculating tools for CVD risk reduction in prostate cancer patients receiving ADT, they offer no formalized approach for identification or stratification of this risk or tools to reduce the risk, and are either too vague to be useful for prostate cancer patients or are not easily implemented in a busy clinic setting. So the whole issue is, how do we go about doing this? And we've gotten the group together, ultimately shown here, where we published a paper in Urology Practice fairly recently, that we came up with some guidelines. But nevertheless, in terms of specific guidelines for patients with cardiovascular disease risk reduction, we're going to follow with some additional recommendations. And while these existing guidelines and risk calculating tools in the US for CVD risk reduction in these patients taking ADT offer no formalized approach for identification and stratification of risk, they're, again, either too vague or impossible to implement in the practice, as I previously stated. So anecdotally, the 360 working group with David runs noted that CVD risk assessment management and current practice is inadequately standardized. So ultimately, a multidisciplinary group of urologic, medical, radiation oncologists, and men's health specialists, and an endocrinologist, preventive cardiologist, yours truly, was recruited based on their experience and expertise in the management of prostate cancer to consider the current challenges in managing CVD risk in these types of men. And here's the group. Many of you are here, perhaps. And ultimately, this group formulated a meeting and ultimately came up with some conclusions that may relate to how you practice medicine in terms of prevention of cardiovascular disease. So for patients who have no history of cardiovascular disease, by the way, if they have a history, they're put in a different group. So you got a guy in the clinic who's got advanced prostate disease, prostate cancer, and ultimately we need a standardized pre-workup before we move into advanced treatment, including ADT. Blood pressure should be measured, BMI, perhaps waist circumference. I'm part of a Lancet commission now, internationally involving 60 experts from around the world on defining obesity. That may seem ridiculous because somebody has a BMI of 40, they clearly have too much adipose tissue. But defining obesity beyond that in terms of ways to measure it and people with borderline BMIs is really a challenge. So anyway, waist circumference may be particularly helpful because it does identify increases in intra-abdominal fat, which is where a lot of metabolic harm comes from. A lipid panel should be part of this. An A1C or a glucose from a basic metabolic panel. You may not have to order an A1C. Urinary albumin-creatinine ratio, you guys in urology should be doing this. And a CVD risk calculator, which there are multiple ones out there, but I'm going to recommend the one put forth by the ACC. And this calculator ultimately gives you an estimation of risk. So here's what that calculator looks like when you plug this in. And again, you may not have to do this. Maybe a nurse practitioner or maybe the primary care from whom your patient was referred should do this. But it deals with things like age and sex and race and systolic blood pressure and diastolic blood pressure, lipids, total cholesterol, HDL and LDL, history of diabetes, are they on a statin, do they smoke, are they on a hypertensive agent, or do they take aspirin? So this is really primary assessment. If the patient has cardiovascular disease, this risk calculator is not worth anything to be utilized. So if we have this risk calculator, based on the results, the patient's going to be considered either in a low, intermediate, or high-risk group. And of note, most prostate cancer patients will be at least intermediate or in high-risk groups based on largely age. Now, ultimately, the ability to get information must be acquired from the patient too. So the patient should be asked if they have a family history of any of these disorders, do they have a history of chronic kidney disease, and ultimately are they being treated for blood pressure, lipids, and/or diabetes. So this is a simple questionnaire. It can be done in your office that, again, you don't need to pay a lot of attention to. Now, ultimately, we're concerned about protecting these patients from heart and other forms of cardiovascular disease. And if any of the questionnaire answers indicate risks for CVD, the high-risk patient can be given a handout to give to his cardiologist and/or internal medicine primary care physician discussing the types of medications that will be initiated. That's your job, to educate the patient and their healthcare provider about the medications to be utilized. As provided by Crawford et al., in the panel's view, men at high risk for CVD should have their cardiovascular health managed by a PCP or a cardiologist, which is why the handout explains what new medications are going to be utilized. So how do we take steps to reduce CVD in men with advanced prostate cancer? I think all patients, the group felt, all patients who are being considered for advanced prostate cancer treatment should receive counseling on reducing CVD risk through lifestyle modifications such as smoking cessation, improved nutrition, increased physical activity, and sleep hygiene. And those deemed low or intermediate risk can proceed on ADT initiation without any further role for you to play in that particular patient. And those in the high-risk group, we feel, can still receive ADT, but a yield sign should be placed so that referrals to a village of other healthcare providers for further follow-up will be required and possible treatment recommendations. And this group has everybody in the world listed here in terms of the PCP, a cardiologist, an endocrinologist, a physician assistant, pharmacist, on down the line. In overall lifestyle assessment for more optimal management, and then consideration, of course, of pharmaceuticals and referrals as needed. So this multidisciplinary team is essential because urologists and radiation oncologists, medical oncologists just don't have the time to do this. They may not have the background or education experience, and I think the patients can only benefit by having one of these other members of the village be involved in this advanced care. And importantly, this tool should be used at least annually. And here's what we recommend to be an annual follow-up of the family history if it existed and wasn't before. Lipid panel should be done annually. An A1C or a basic metabolic panel. EGFR should be assessed annually. That's current guidelines. Waist circumference measured if changing, and a 10-year risk carried out in people who do not have known disease. So here's my summary. The assessment tool identifies the CVD risk evident in many men with prostate cancer, which can be exacerbated by treatment It also empowers urologic oncology providers who are comfortable with managing CVD risk factors to provide comprehensive care, but otherwise we feel that ultimately a referral to a village is necessary, and two processes are essential: good communication between you and the provider village, and then delegations for decisions to follow to these people who are part of the village tool. And finally, CVD risk in these patients is not static. It changes with age, disease progression, and treatments. So cardiovascular disease must be continually assessed over the course of the patient's life. So thank you very much for your attention.